So we're looking at perihepatitis with the common form known as Fitz-Hugh-Curtis syndrome. In early 1900s, cases of women with right upper quadrant pain and pelvic infections were described, but the cause was not yet clear. In 1930, Arthur Hay-Curtis, an American gynecologist, reported the association between pelvic infections and perihepatitis, describing the characteristic violin string adhesion between the liver capsule and the abdominal wall or diaphragm. In 1934, Thomas Fitz-Hugh Jr., an American physician, independently described similar findings in women with gonococcal sarcoiditis, that's fallopian tube infection. The condition was therefore named Fitz-Hugh-Curtis syndrome, honoring both researchers who identified and described it. So, perihepatitis is inflammation of the liver capsule, also known as Gleason's capsule, without primary liver disease. The classic form is called Fitz-Hugh-Curtis syndrome, seen as a complication of pelvic inflammatory disease. So what are the causes? The most common cause is spread of infection from the female genital tract, especially in pelvic inflammatory disease due to chlamydia trachomatis and Neisseria gonorrhea. Less common, you expect it in tuberculosis, appendicitis, or other intra-abdominal infections. So what is the pathogenesis? Infections ascend from the cervix to the uterus to the fallopian tubes and finally into the peritoneal cavity. Bacteria/inflammatory exudates reach the liver capsule. This causes inflammation and adhesions between the liver capsule and anterior abdominal wall/diaphragm. The classic finding is violin string adhesions between liver and peritoneum. So you can see the violin string adhesions here between the liver here and the peritoneum up here. So what are the clinical features? Sharp right upper quadrant pain worsens with breathing, coughing, or movement. Pain may mimic gallbladder disease or pleuritis. May be associated with fever, lower abdominal/pelvic pain, vaginal discharge. These are features of pelvic inflammatory disease. That's an indication that it is usually common in pelvic inflammatory disease. Tenderness in right upper quadrant on exam, but liver function test is usually normal since the liver parenchyma itself is not involved. So how do you make diagnosis? Clinical suspicion in a sexually active woman with pelvic inflammatory disease symptoms plus right upper quadrant pain. So when a woman presents to you, you ask her, is she sexually active? If yes, does she have pelvic inflammatory disease? Is it presenting with symptoms plus right upper quadrant pain? You do laparoscopy, which shows violin string adhesion and it is diagnostic. You do ultrasound/CT, which may help exclude other right upper quadrant pain causes. You can do cervical swabs for gonorrhea/chlamydia. So how do you manage this? You give antibiotics for pelvic inflammatory disease, e.g. ceftriaxone plus doxycycline plus or minus metronidazole. You give analgesia for pain relief. You do surgery, that's laparoscopic adhesiolysis, only if severe adhesion causing persistent pain. Here is a quick recall. When you think of perihepatitis, you think of right upper quadrant pain plus pelvic inflammatory disease. You think Fitz-Hugh-Curtis syndrome with violin string adhesions. Thanks for listening.